joining?
Yeah.
I'm still joining.
Wow.
You are?
And
And Amy is still
active
Amy.
in the
Pardon?
No,
And I'm still
Me
I just walked in.
Yes, exactly.
Sorry.
All right. Thank you all for coming. I wasn't sure we'd even have anybody this morning since we're up against some stiff competition for people's attention. But I am really, I'm just thrilled to be in the space with Amy and to really get to listen with some careful attention to the information that she's going to bring forward for us. Really trying to get my head around the concept of a maternity care home. When I first heard about medical homes and then maternity care. Can I speak up? Sure. And if I fade, remind me, because I do fade. So when I first heard about medical homes, I was and then when I heard about maternity homes, I thought, whoa, really uh-oh. Because I think of, father knows best. So those of us of a certain age remember Dr. Welby and father knows best is the same person. And I can just imagine who would be the dad in that home. So it's exciting to think about how that might play differently, specifically around maternity care homes. The other thing is that I am on the board of directors of the Academic Consortium for Complementary Healthcare Providers, representing midwifery. And I, in that capacity, was asked to write a piece of a white paper on primary care, on innovations in primary care, in which naturopaths, chiropractors, acupuncturists, orientalists, medicine physicians, massage therapists, and midwives would each have a section in the white paper to talk about the contribution that each of those professional groups might make to innovations in primary care. And I found it really challenging. First of all, I found it challenging because when you're talking about primary care, just like with the OBGYNs, there's sort of this immediate assumption that you're talking about the full range of primary care services. And that's not appropriate for CPMs. We don't have that scope of practice, and we don't want that scope of practice. And so there's just an initial wall that you have to get through to say, primary maternity care is a legitimate concept, and it's a contribution that midwifery can make to a whole system of primary care. And it's not just a carve-out like primary cardiovascular care. It's not. It's something that's really different in the healthcare picture. So I had to get through that. Then I tried to find information about primary maternity care because I think that's a concept that ought to be understood, and it really doesn't exist, particularly in U.S. literature. You can't find literature about it. You can't find, statements that define it. It was really, really challenging. And the best I could do was Canadian. Was the closest that I could get. And in fact, we had someone scheduled who, unfortunately for health reasons, was not able to come. But then Murray Davis from Canada was going to come down and talk about the primary care, maternity care collaboration in Canada. And then the other barrier I had to get through was in talking to my colleagues, the midwives, who were like, "Oh, primary care. We don't want to do that. That means you have to have prescriptive privileges and you have to have this and that." And I was like, "No, it doesn't. Why does it have to mean that you have prescriptive privileges? I don't get it. You're primary maternity care providers right now. That's what you do. That's who you are. You screen, you care for, you refer when necessary. Come on." So I did the best I could in drafting my piece. That's the contribution to the white paper. Meanwhile, for a variety of, and I finished that last June, meanwhile, for a variety of reasons, the paper is sitting on the principal co-authors' desks. And thank goodness, because I think now in the last year and with the work that Childbirth Connection and Amy in particular are doing, I think we can rewrite it and really make it a different paper. No, I mean, it's going to be so much better. So, so really, all I want to do here today is sit down and shut up and let me, it's hot. And so what I did was I brought along 10 copies of my paper. I wrote draft, not for publication on it, but and please know that it was written nearly a year ago and it's going to get revised. But I hope part of the revision will come from you all giving feedback. That would be very helpful. And tell me what we need to say about the role that CPMs can play in primary maternity care. The paper is organized in sections. That's first an introduction, and then the structure of the white paper overall is that each professional group then addresses internal disagreements over primary care, the role of the profession in primary care, the practice model, including referral and co-management, evidence of patient use as a first contact provider, evidence of wellness, health promotion, and primary prevention services, governmental or regulatory agency recognition as primary care providers, third-party recognition as primary care providers, research relative to the topic, professional goals or objectives related to primary care, comparative educational standards for primary care practice. Now we've got the icing on that, I've got to get more of that in there. Focused education to enhance skills, barriers to a greater role, and rethinking primary care. So those are the topics. And again, I welcome your feedback, please. And I'm going to pass these around. There's not enough for everyone, so don't take it if you don't want to read it. Or if you'd rather have it electronically, I'd be happy to send it to you. So,
what would be the best way to connect with you to get an electronic
I put my
copy?
email on there, so it's jciecko@wildblue.net.
Can I make a comment before we start?
You bet.
Just noting that you noted the stiff competition to this particular session, and doesn't look like we have a lot of representation of women of color in the room. So maybe that we could all kind of take the challenge of putting on the lens of looking at, you know, these presentations and any questions that we may have for Amy or for anyone else here, of the lens of who's going to be most affected by the outcomes we're looking at. And so that we all just keep that in the forefront of our minds so that the questions get asked despite who's in the room.
Sarah, that's brilliant. Thank you.
Yeah. Let me say that Matt has already thought of these things, and I am a social justice watchdog. So,
Lots of people have already thought of them.
right. So we try to distribute, you know, somebody around who's kind of paying attention to that. So.
Excellent. Watch that.
Thanks.
So you're here in the official capacity.
If we hear that, we go work. Okay?
Yeah, I'm ready. Yeah,
Cool.
I'm just,
I want you to have as much time as we've got.
thanks, Joanne. So I've been like chomping at the bit to start talking and writing more about this. So this is my first time. I do a lot of talks that I kind of do and then I tweak them and whatever. But this I did from scratch, and I really hope there's some time for good conversation at the end of this. So you're my guinea pigs. And I can't, for some reason, see my slides here, so
Yes.
apologize for doing this.
Do you want to have some?
That's what I was trying to do just before I got up here.
Right.
But I'm going to
Matt
project
came in and tried to fix it.
I'll figure it out. But you can tell me if you can't hear me. So, you know, I think the rationale, first we need to sort of figure out why we're even talking about primary care, primary maternity care. And I'm going to be a little bit, I don't want to use the word schizophrenic because that's probably not like the right word, but a little bit like, you know, talking about primary care as we traditionally think of it, and also talking about kind of a new understanding of primary maternity care. But for the beginning, I'm just going to sort of talk about them together. And the reason that we're talking about primary maternity care, if you just normally think about it, is that, it's about a population of people, and the goal is to keep them healthy, to screen them for disease, to, triage them to the correct level of care. And so really, all of those things can be said of healthy pregnant women, and even pregnant women, along the spectrum of health. So we see common needs in the populations that primary care providers and maternity care providers deal with. We see common models of service delivery, which we're going to get at in a minute, or I don't know how many minutes. Common obstacles to delivery of these services. And then I cannot stand in front of you and talk about primary and maternity care without saying that, of course, pregnancy and childbirth are part of the healthy experience of life, and really they ought to be part of a cohesive primary care system, but they are totally carved out right now. We see examples of that right and left, and one of the things that Tim didn't get into in his workforce discussion this morning is that the family practice profession, which, in addition to midwives, have been primary maternity care providers, and are also actual primary care providers, they're having some changes in their residency standards that are going to make it easier to get through a full family practice residency without gaining confidence in maternity care, or at least in the intrapartum part of maternity care. So we're going to be seeing less and less of a contribution from family practice in this area. I know, it's really scary. It's scary what's happening. So again, this is a call for midwives to fill that void. Right along. So we're going to talk about what do we mean by primary maternity care. I really want to start having a common language that we can use and get out there and talk about. So we're going to spend some time on that. And then we're going to talk about the role of midwives in delivering primary maternity care, and look at some recommendations and opportunities. So first we're going to take a look at primary care, because I don't know about you, but I don't have very many good models of primary care. I haven't been to a primary care provider in an embarrassing number of years, and that was the first time I'd gone in some other embarrassing number of years. So I don't have a model that I can really look to on a personal level. So let's just define primary care, and sorry, I am going to read this. The provision of integrated, accessible, oh, my colors aren't so good. Anyway, I wanted to highlight words. Integrated, accessible healthcare services by clinicians who are accountable for addressing a large majority of personal healthcare needs, developing a sustained partnership with patients, practicing in the context of family and community. And that's an Institute of Medicine definition that's, a couple of decades old now. But I think it still stands, and it still stands. And there have been other attempts to define primary care, and they all have kind of common elements. And these are the ones we see. One that we didn't see in that last version was this concept of first contact. It's kind of the person's entry into the healthcare system, which for maternity care is particularly interesting because for a lot of women, this is really the first entry into healthcare, period. And we have an opportunity to model good service delivery and good care and really set the tone of what a healthcare experience can look like. And, help her gain access to other parts of the healthcare system that she's going to need access to as she now has children and has to deal with pediatric care. And unfortunately, pregnancy, especially the way it's delivered currently, the way care is delivered currently, can really trigger a lot of chronic disease, obesity, unfortunately that's the case. So anyway, we know that women are more likely to be consuming healthcare services after their childbearing experiences than before. So the goals of primary care are kind of obvious, but I wanted to put them down there and see that basically the idea is, keep as many people healthy as we can, take a population view, be individualized with our care, and then find those people that need more healthcare services and get them the appropriate services in partnership with them to understand, what they want to get out of those interactions. And this is something when you spend time thinking about healthcare, policy and whatever, is a phrase that you hear a lot, different versions of it. But basically, the primary care at an individual level is kind of what I just talked about. But the system that delivers primary care is trying to get the right care at the right time to the right place from the right person for each person in the system. And so we're going to break that down. These are the challenges facing primary care. As we talk about primary care in the United States, and they should be very familiar to us. There are a lot of the same problems, in fact, all the same problems that we see in maternity care. And I'm not going to go through them. I just want to wanted to show you, we've got a pretty sick primary care system in this country too, not just maternity. And so I'm going to take some time we're going to get back to these, but I just want to show you what people are talking about when they're looking at, the state of primary care in the United States, what they're thinking of as ways to fix the really significant problems that we're seeing. So patient-centered medical homes, which is, I know we don't all share the same understanding of what that is, and I'll get into that later, but okay, so that concept. House calls? How many of you guys do house calls? Some portion of it, right? Okay, group visits, what an innovation. Leveraging new technology, there's a lot of interest in technology, everything from, health records and connecting, the flow of information, but also maybe done like a Skype consults for breastfeeding, so these are the kinds of things that people are talking about for primary care situations as well. Non-physician providers, multidisciplinary care teams, shared decision making, and then a whole host of innovations that reduce preventable hospitalizations and rehospitalizations. So that's like a whole category in and of itself. So here are innovations. So what is primary maternity care? All you have to do is swap out, health care for maternity, or health for maternity in that last definition we saw. So provision of integrated accessible maternity care services, accounting, looking at large majority of maternity care needs and context of family and community, important. So turns out there's been a definition for, as long as there's been a definition of primary care, there's been a definition of primary maternity care. Visionary group of women who I work alongside, one of them, Carol Sakala and Judy Luce. It was like 4 organizations that... Yeah, really standing on the shoulders again. So they wrote a report called Childbearing Policy Within a National Health Program. You can't get it online. We had to maybe resurrect it or something.
I think we should. I have one precious copy.
And it's from 1994, spiral bound, written around the kitchen table kind of thing. But they define what the elements of primary maternity care are: education, health promotion, preventive clinical services, social support, continuity of care, accessibility, cultural appropriateness, and location in and orientation around communities. This one slide doesn't even do the report justice. It's really good, and it was trying to take advantage at the time of an opportunity when there was a conversation about healthcare reform, and that was the Clinton era, and that conversation didn't go anywhere, but we're in a conversation that hopefully is going somewhere now with healthcare reform legislation. So what are the goals of primary maternity care service delivery? If we kind of zero in a little on maternity care, these are going to look familiar. The right care at the right time in the right place by the right person. Okay? We're going to break these down a little bit. This is some work that I kind of developed. When I was thinking about the right care for women, there are kind of 3 categories of that. There's the basic care that applies to every last woman in the system. And there's condition-specific care, and we're going to kind of look at these separately, and preference-sensitive care. So let's look at childbearing needs. And I'm sure in this room we could probably come up with others that are sort of basic needs, but these are examples of basic care needs of all childbearing women. So respectful care, emotional support, culturally appropriate, support and respect for informed decision-making, safety, guidance for helping them understand, what the process that's going on with their body and how to stay healthy and how to care for themselves and their babies. And then, safety is the last thing there. And then as we move on to condition-specific needs, these are, it kind of depends on the woman's situation and how much care she needs to get through that pregnancy and birth safely. Information and guidance to self-manage conditions or modify behaviors, so things like smoking cessation or diet issues. That, kind of depends on the woman and where she's at with that stuff. And then there's a category of effective care options that we know, ought to be applied. So women with, a history of a prior preterm birth, there's some evidence to show that certain kinds of interventions can help her avoid a subsequent preterm birth. And so the application of effective care, and I just want to remind everybody, I don't need to remind this group that those should be delivered with the woman's informed consent. Just because something's evidence-based, it still may not apply or be appropriate or wanted by a particular woman. And then, enhanced support for women with challenging social circumstances or risk factors. And so really, intensifying the care, not the procedures and stuff, but intensifying the care that we give to some women who just need more attention. Or, helping her arrange that support from others. And then preference-sensitive care, anybody, have we heard this term in here? Okay, so this is a term that I've become much more familiar with over the last year or so, working on the shared decision-making project that Childbirth Connection and then Informed Medical Decisions Foundation have been involved in. And so preference-sensitive care is a lot. It comprises a huge amount of the care, decisions that get made, because it's basically anything that either there are multiple medically appropriate options that a rational person might choose because there are benefits and risks and there's some trade-offs there, or this is the one that probably comprises the largest amount. There's just insufficient person-centered outcomes data leading to clinical uncertainty about what the best course, what the best option is for an individual woman. There are so many questions that we just plain don't have answers to, and so we make a lot of decisions in the context of imperfect and inadequate information. And then there's sort of trade-offs where, I can't decide what's more important for you, this slightly lower risk of a stillbirth versus this higher risk of something else. So, here's the information about the risks and you decide. And so that's kind of the essence of shared decision-making. Shared decision-making came up around these preference-sensitive care decisions to really give information that, the best evidence that we can gather to women, help them interpret it and understand it in the context of their own situations, and then also, importantly, to help them clarify their values and figure out, based on my values, what's the best care option. So we've got those. Yeah.
I ask a question, the insufficient person-centered outcomes now, you're looking for good outcomes to prove that person-centered care works?
No, sorry. Those are that was a slight modification of a term that's kind of used a lot in the comparative effectiveness research world of patient-centered outcomes data, outcomes research. And what that is there's a really tiny proportion of all of the medical research that is that's published that actually produces data on outcomes that affect an actual person. It's like data or a person, an outcome that a person would actually care about, which would be enhanced health, not dying, those kinds of things. And so there's a lot of data. An example would be data on some intervention that results in some kind of change in APGAR scores from an average of 8 to an average of 9. APGAR score is just a number. It's a number that we use as a proxy for some concept of infant health, but we know that it's really poorly correlated with any meaningful outcome for that baby, especially when we're looking at extremes of APGAR scores, because we know that most babies, even with low APGAR scores, they're fine. It's just a number. So that's called a proxy measure or a surrogate outcome kind of thing. So an opposite of a surrogate outcome or some sort of biological phenomenon that you might be able to measure using research instruments would be an actual, this improves health, it improves functioning, it improves, it reduces the likelihood of mortality, that kind of stuff. And so we've got a lot of, another one that's used frequently is duration of labor. We've got a lot of evidence that Pitocin, alters the duration of labor, but is that meaningful to a woman? It's meaningful to a doctor, we know that, and to the hospital. But some women that might be meaningful too. I want to know that I'm going to give birth in 12 hours or less or whatever. Sure, then maybe she might be a little more prone to wanting Pitocin in her labor, but faster labor isn't necessarily better, and it's used as a proxy for, you see it constantly used as a proxy for C-section, but the things that shorten labor don't reduce C-sections necessarily. Did that answer your question?
I think.
Could it also be used, when researchers rate the effectiveness of data that they end up with? That really is the one where you have clinical expertise or clinical judgment that you're using, but there's no clear evidence to correlate the option with the outcome. Yeah. You've just seen it happen in women that if you do X, you can offer that as a choice and she may want it, and you've seen it work. But there's no clear data. So it's the lowest level.
Well,
it's basically expert clinical judgment.
Person-centered outcomes, or
pardon?
Person-centered outcomes data are clinical, would be not clinical judgment. Would be, so an example, I'll give another example from outside maternity that's used frequently, is that we know that statin drugs can lower cholesterol. and the idea is then they must be beneficial for cardiac health, but it turns out that they don't, and don't quote me on this, but for certain populations of patients, they don't reduce the likelihood that you're going to have a heart attack or that you're going to die or whatever. So you're reducing a lab value, basically. You're taking a drug to reduce a lab value. That's not a patient-centered outcome.
I have a great example.
Yeah.
I might, maybe this will help.
Yeah.
This is an FDA example, actually. There's been a lot of discussion, and there was we actually had a public advisory panel with the use of lap band in reducing weight. Okay, and we just increased the indication where now people who have a BMI of 30 to 35 can get a lap band, and we're still talking about that because we have concerns about it's going to change practice. But the discussion within the experts on the advisory panel were, well, what does that mean if you lose weight? So you lose weight and you keep it off for 5 years. Does that really improve your cholesterol levels? Does that really decrease your potential for getting diabetes? Does that really decrease your potential for having a cardiovascular event? And we don't have that answer whatsoever. We don't know. Now, we're hoping to study that, and we've actually, the study that we now have issued an order for is going to study that instead of do you keep the weight off, because that's the measure of effectiveness or durability of whatever it is. But what does it mean?
There's infinite numbers of things that you can measure, but most of them are meaningless or poorly correlated with the things that we care about.
So the hard things.
Yeah.
And the hard things
Yeah, it's hard to
don't mean
measure, actual health. So we measure other things instead, and we pretend that we know
That's
something.
why we don't do it.
Yeah.
It's hard.
We know. So anyway, so there it is. Okay, so we had the right care at the right time. We got through the right care. The right time, I've seen actually people really bristle about the idea of timely maternity care, but this is the definition from the vision statement that Childbirth Connection and our partners came up with, and we address timely both in, I think the first one is the most important. Timely means that the timing of the onset and course of all stages of labor and the birth of the baby are determined by maternal fetal physiology, and then we also get at timely discussions so that we're not having conversation for the first time about the risks and benefits of epidurals when the woman is screaming in pain. Okay, so that's an example of timely, shared decision-making processes. And then the sort of typical, she shouldn't have to wait 2 hours or 6 weeks to have her first prenatal visit or something. I love this quote from the World Health Organization. The right place for maternity care is the most peripheral level, where the birth is feasible and safe, and where the woman feels safe and confident. And so that is going to depend on, the woman's preferences, geography, the resources of the various settings and whatever, but that's a hard one to argue with.
There's an updated one in 2005.
Oh, is
health report.
Is it a similar quote?
Well, what it says is the most appropriate place for women to birth is in a community-based birth center with a midwife.
Ah, even better.
It's
Exactly.
It's in 2005. World
World
Health
Health
Report,
Organization. All right, if I
which
can't find it
deals
on.
with.
They just can't say it, can they?
millennium development goals.
Bring themselves to do it.
These are a couple other quotes I like a lot. The right people. It is inherently, I'll do this one in a British, no, I won't do it. Is it British or Canadian? I can't remember. It's inherently unwise and perhaps unsafe for women with normal pregnancies to be cared for by obstetric specialists.
Whoa.
Yeah. Midwife-led care confers benefits and shows no adverse outcomes. It should be the norm for women classified at low and high risk of complications.
Well, I like the way they include the high risk because those are
Alright.
the needs most.
Well, we're going to get to that. And these quotes actually say two different things, and we're going to look at that. Because the question is like, what do you mean high-risk women? I thought that, maybe some of us don't have that same concept, but certainly a lot of people have the concept that midwifery care is for low-risk women. But midwifery care and midwife-led care are two different things. And that is the essence, that's the essence of what we're talking about today with midwife-led primary care. So, the right care, getting at that thing again, the right care, it depends. We don't know what the right care is. It depends on the individual woman, and it can change over the course of her maternity care episode. So we need to build a system that can deal with that changing nature of the right care. So we have to build a system that can match each woman with the right package of care and coordinate the services. Because also care is a lot of different things. There are a lot of different things that we do that add up to, care for a woman. And so, what's that package of care, and how do we know it's the right one? And that if it turns out that the care package that we've built for her isn't the right one, how are we going to modify that package as we move along? But going back to the right care, the 3 bits of right care, the first one is the basic one, and that's the one that applies to everybody. And hey, by the way, it basically aligns completely with midwifery expertise. So there's a really strong argument for midwives to be frontline primary maternity care providers, provided that we can build the other systems around that can ensure safety and appropriate care. Geese are out of here. I like what I have to say. So these are, I'll go ahead and pitch my book. So I have a book coming out in June with Nancy Gower, Optimal Care in Childbirth, The Case for a Physiologic Approach. And so this chapter is kind of what built this talk. So this is the midwife-led care chapter. So these are the core competencies as I see them. And again, I'd be very open to other input. But this one I'm not going to let anybody talk me out of. Proficient in the delivery of physiologic care. I just wrote a book about that. Skilled at providing physical comfort, emotional support, and health education and promotion. Culturally competent. Able to identify problems with or without sophisticated technology. Because, right, we're at the most peripheral level, potentially, wherever that is. Skilled at managing or stabilizing common problems that present in pregnancy, labor, birth, or the postpartum period. And aware of the limitations of his or her scope of practice and willing and able to engage others to fill that void. And I just want to point out that one of the limitations of some people's scope of practice is physiologic care. So if an OB is providing providing the services for a woman, that OB needs to figure out a way to get that primary care element in there. But also, of course, midwives have limitations of our scope of practice, but I see them as overlapping and complementary if we just figure out how to work together.
Could I say something as the dog? The culturally competent phrase.
I know.
Somewhere in there. No, it's not that it's wrong. It's that it's not enough.
Right.
And I mean, speaking for myself, and hopefully you would agree with that. That's a component people are talking about today. Like, who are those care providers, and what does that mean, culturally competent? I take care of a large Sedum Jewish population, and I'm not Jewish.
Right.
So, but over the years, I've learned what it is I need to know to be able to make that comfortable for them. When they look at me, they're glad I'm not Jewish, because on Sabbath I can kind of, you can turn the lights on. Right, but being culturally competent, we need to, it can't just be that. And
I would be
feel
very
like we're
open to
always covered, because it's not enough, is what we're hearing.
I have to say, Linda, in this context, because I taught students at NYU for years, and we really made culturally competent components an essential part of the program, based on the premise that nobody can be all things to all women, because we all come from where we are with our genetic makeup and our skin color and our historical background of whatever. And again, we used to not even use the word competent, because it's impossible to be culturally competent with the mix of women you're going to see. But nimble. I like that, culturally nimble. Most critically, I think, whatever phrase we use, that you at least respect and get the woman to give you the feedback about what it is she needs in a given context at a given time during her course of care. Think rather than imposing what you think she needs.
Responsible to culture.
And that's as much patient sensitive as it is culturally competent.
And also we're building this sort of, we're not trying, we're the primary maternity care provider, so we're not trying to provide every need that she has. And so engaging her family or her community or her, religiously, whatever it is, if that's outside of our scope of practice to understand, every ritual that a certain religious group has, then we need to figure out a way to deal with that gap in our
we need to deal with that phrase. We need to be conscious that when we're throwing that around, that we all need to be culturally competent. That's a whole huge thing that needs to be explored. And
I
Right.
totally understand the power of language, and I know that I sometimes don't get where I understand it. But there it is. Oops, today. Okay. So here are my 3 recommendations. I was asked to give the recommendations of the blueprint from for action, but when I went to the blueprint for action, I was like, ooh, it's really kind of all threaded through, and that's because when you look at the vision, which was our paper that came out before the blueprint and set the stage for the blueprint, the vision is a system of maternity care built on top of a primary maternity, or built on a base of a primary maternity care system. So these recommendations are my recommendations, but we're going to use some of the blueprint material to get at what we need. So midwives must demonstrate the outcomes and value of our care delivery innovations. We're going to have a redundant epiphany moment with that one. Midwives must be involved in the design, demonstration, implementation, and evaluation of the Women and Family-Centered Maternity Care Home. We're going to talk more about that. And midwives were skilled at engaging women, but we need to now engage with all stakeholders. We got to use those engagement skills and really kind of spider out from the center and be at all levels of the system that are impacting the maternity care experience. So these are the innovations, right? We don't have to do anything new. I mean, there are some things we need to do and improve in midwifery care, but we're doing these things. These are the innovations. We just, when people make big grants for innovations, we don't have to say, what am I going to do to like what's new and cool? We're going to say, we've been doing this all along. This is a redundant epiphany. It's a redundant epiphany. We're doing a house development, but that's not in that one grant. But group visits, probably like the people in this room that are doing sittering or something similar. So these are, I don't want to belabor this, but I just, I do think that kind of a collective aha moment of this meeting has been that we're doing something that outsiders see as innovative, and we just need to use that language and get out there and say we're innovating. We've been doing it all along. So the Blueprint for Action, one of the high-level recommendations is to extend the healthcare home model to the full episode of maternity care to ensure that every childbearing woman has access to a woman and family-centered maternity care home that fosters care coordination. And I've sensed some discomfort with this concept and this language, but I hope that we can come to like a common understanding. And I mean, maybe we need different language for this, but the concept I think is good. And there was some attempts early on, and also some pressure from the sort of larger healthcare community to say, like, no, the whole point of the patient-centered medical home is not to like have all these specialty medical homes. We need the medical home, and that's it. But then when we started seeing the concept of patient-centered medical home develop and the sort of standards for that, it was like, where's maternity care? It's not even in there. It's not, literally you could do like a word search for it in the hundreds of page document about a patient-centered medical home, and you wouldn't find pregnancy in there at all. So, but we are in a position to define this. This is not a concept that has a really strong definition described. And I emailed Carol as I was doing these slides. I was like, "What's the best definition for women-centered family-centered maternity care home?" And she wrote back this kind of exhaustive thing about like, "Well, there's some good language in here, and there's." I was like, "Thanks, you answered my question. There's no one definition. Okay, it's an evolving concept with growing interest among stakeholders. Payers are bought into this, okay? And, we talked about the patient-centered medical home, but I know we don't yet have a common understanding of what that is. But this is, probably the hardest slide to read. Want me to just read it out loud? So, no? Okay. So elements and features of a maternity care home. It's basically like what we are either already doing or know we need to do better, okay? It's like we're providing, we're taking care of her health needs, doing the preventive care stuff, helping her make her decisions, individualizing care,